There it goes. Alrighty, so this is the section, chapter 2, chest section, and I've picked and chose some of the most important things to talk about here. So we're going to start with the basics of anatomy for the chest. The first thing to get is that we divide the chest up into different anatomic structures, okay? So there's three broad divisions that you want to make for the chest. There's the bony stuff, called the bony thorax, thought of as a protective framework, although it serves other purposes. For example, muscular attachment to allow for breathing. Protective framework is a good start, though. There's the respiratory system, in which you consider the lungs and the airways. And then there's the space between the lungs called the mediastinum. Space between the lungs. There's a lot of important stuff in the mediastinum, such as your heart, the great vessels coming into and out of your heart, your esophagus leading to your stomach, your thymus gland, which is a gland of the endocrine system, your trachea, which leads to both lungs. It's a breathing tube going to both lungs. So lots of important structures in the mediastinum. And then there it is, though. There's our three divisions to the chest. The bony stuff, the breathing stuff, and then everything else. When we take a chest x-ray, most of the time, if a patient asks you, why are you taking a chest x-ray, usually our response is we're looking at your lungs, right? That's true, but we're also looking at everything else too. The bony thorax is a part of the chest x-ray evaluation. You can see things pathologically wrong with the bony thorax on chest x-rays. Although there are specific images for chest x-rays, you're going to be able to catch some of these there are specific images for bony thorax, but you will be able to catch some of the pathologies on chest x-rays.
About 6 months ago, a patient came in. She came in for some pain that she had been having chronically in her right shoulder, I believe.
Mm-hmm.
With that image, we get a little bit more of the anatomy around the area.
Right.
So we were looking for pain, but we noticed that there was abnormalities in her lungs. So this lady, without ever going to the doctor, she ended up having really late stage cancer that had already spread to her lungs.
Yeah.
So we caught that by accident because we were looking for something going on with her shoulder.
Right.
So her cancer trumped the shoulder issue.
Like, turn it around and say, I've taken chest x-rays on people, and we've caught osteosarcomas, bone cancers on a chest x-ray in their shoulder, right? We've seen that in their shoulder because it's included, in some cases, on the actual chest x-ray image. We call these things that are found on an x-ray image that we're not going looking for, like the metastatic cancer in the lungs on a shoulder that you saw on a shoulder x-ray. You're not looking for metastatic lung cancer on a shoulder x-ray, but you saw it, right? These are called incidental findings. We found them when we weren't looking for them. Incidental findings. Okay, three parts of the chest division. Let's talk briefly about the bony thorax, and then we get to move on. The bony thorax is made up anteriorly of the sternum, or breastbone. The sternum is made of three pieces. Up top, the manubrium. You can feel the top of your manubrium. It's called the jugular notch, that little depression you can push in on. Okay. If you feel close enough here, you can find your manubrium. You can sort of move down, and then you'll find like a small little horizontal depression, right? Your manubrium is about yay big, and find the top of it, work your way down. You can find a little horizontal depression where it goes from manubrium to body of the sternum. The majority of the sternum is called the body. It makes up the main mass of the sternum. Aside from muscle and skin, the sternum is the most anterior structure of the chest. So the sternum is anterior to the lungs, anterior to the heart. Everything in the chest is posterior to the sternum. Inferiorly on the sternum, at the bottom of the sternum, is the xiphoid process or xiphoid tip. Xiphoid pronounced with a Z, spelled with an X. considered part of your bony thorax, but also part of your shoulder girdle, making up your shoulder, are your clavicles or collarbones. They're considered part of your bony thorax because they attach directly to your sternum. Your clavicles come in and attach directly to your sternum. Your scapulae, which are your shoulder blades, those actually have no bony attachment directly to the bony thorax. They attach to the clavicle by bone. The clavicle attaches to the sternum by a bony joint. However, the majority of your scapula and clavicle, and for your shoulder for that matter, are not attached to anything, which allows you to do all kinds of fun stuff with your shoulder. You can move them all around, all over the place, and you have all that movement because they're only attached in one spot. Your shoulder is only attached by bone here, where your clavicle touches your sternum. There is no other bony attachment to your body for your shoulder. There is attachment, it's muscle and tendon and ligament, but the only bony attachment is by clavicle. You have 12 pairs of ribs that attach in the posteriorly in the back to 12 thoracic vertebrae. Each thoracic vertebra has a rib coming out of each side. So each thoracic vertebra attaches to a pair of ribs. We call the thoracic vertebrae our T-spine, and we label them T1 through T12. Shown here, you're looking at the chest laterally, so you're looking at a side view of the chest. That gray outline is, of course, the lung field. The thing to take away from this is, look how high the apices, the top of the lungs, extend. They actually extend above the clavicles in most females, okay? In most males, they stay just below the clavicles. They can go up to and maybe a little bit above, but typically they stay just below the clavicles, okay? On a chest x-ray, they will extend above the medial aspect of the clavicle on a male, but they'll never extend above the AC joint, which is the lateral aspect of the clavicle. And you can see that on these chest x-rays, you can see the clavicles, hopefully, and the black of the lung fields, and noticing that it never goes above the top of the clavicles. It never goes above the highest point of the clavicles. But on females, that's typically different, okay? So there's a difference in anatomy, general anatomy between male and female, and you may have to adjust for that, okay? Things to think about, bony landmarks that you can find on the body. I showed you one of them already. That's called your jugular notch. That's right here in the front, okay? 4 to 5 inches down from the jugular notch is your mid-chest, which is roughly the width of your hand. Okay, you're going to need at some point to measure how wide your hand is, okay, to use that as a measuring tool. From the jugular notch, one hand's width down on most average size hands, about 4-ish inches, gets you down to the mid-thorax. The mid-thorax here is the level of thoracic vertebra 7. There's 12 thoracic vertebrae, but because the lower ones are bigger, the 7th one ends up being the middle. Okay. Posteriorly, most of the time the patient's facing the image receptor, so the jugular notch is not a great bony landmark because usually their back is facing towards you. So from the back, you want to find another bony landmark, and that bony landmark is called the vertebra prominens. And you can go right to the back of your neck, you know where it's at, it's a hump on the back of your neck. Find that hump on the back of your neck. That hump, if you can put a finger right on it, that's your vertebra prominens, okay? From the vertebra prominens, about 7 to 8 inches down is your mid-thorax. So you can find mid-thorax from the front and the back. Why do you need mid-thorax? Well, that's the middle of the chest. Wouldn't it be useful to know where the middle of the chest is so you can line everything up? It is. The way to use your hand as a measuring tool in this case, I see Enrique doing it, spread your your pinky finger and your thumb as far apart as they can, okay? Measure that distance, know what that distance is on yourself, okay? And then use that as your measuring tool, okay? From vertebra prominens, where your thumb, put your pinky on vertebra prominens, let your thumb touch wherever it's touching on the back, that's usually mid-thorax on most people, okay? Again, it's different, a little bit different for everybody, but on average, 95% of us have roughly the same size hand. So I know all hands vary slightly, but on average, our hands are roughly all the same size. They don't vary that much in adults. Okay. And lastly, last bony landmark, to find the bottom of the lung field in the front. There's no great way to find the bottom of the lung field in the back, but in the front, you can find the xiphoid tip, the xiphoid process. On yourself, you can sort of find where your ribs sort of start to come together, and where they come up to that point, you can poke right there and find your xiphoid tip. That's the bottom of your lung field anteriorly. Okay, that's lung field.
Is your diaphragm is not connected to the xiphoid, it's
No.
it's connected to the walls of
The
interior.
Yeah, and
I'm not sure what
the
to call
thoracic cage too. Yeah,
the knowledge kills.
it's the separation though between abdomen and diaphragm, or abdomen and chest. Okay, let's talk a little bit about the respiratory system. Okay, what it is, what it's good for, what it looks like. In a chest X-ray, we consider the respiratory system all the way up to the trachea. Okay, so you're actually looking at the air-filled trachea in the throat on a chest X-ray. Now, on some of these, it's cut off a little bit low, but I'll show you there is a visible trachea on every one of those chest X-rays, and so we need to know all the way up to that point. Now, unless we're taking like a soft tissue X-ray of the neck, the rest of this upper respiratory anatomy becomes less important. But let's talk briefly about it. The purpose of the respiratory system is to exchange gas with your blood. That's it. It's to take the gas that's out here in the room, nitrogen, oxygen, other things, get it inside the body, and bring that gas right up next to your bloodstream. And what do we want to happen? We want the gas that we need from the atmosphere to go into our bloodstream, and the gas that has built up as a waste product in our bloodstream to leave the bloodstream and come out of the body. That's why we breathe, right? This is called bulk flow. Bulk flow is getting a large amount of air into one spot in the body. Once it's in there, the way gases move into and out of the bloodstream is by diffusion. Diffusion is pretty simple to understand. It's not. I can talk about it. Cream into coffee, right? You take a cup of coffee, yeah, and you take let's say a tablespoon of cream, and you dump it into the cup of coffee, right? That cream is its own little chunk of cream, right? Hopefully it's not a chunk, but you get the idea. It's a volume of cream, okay? You put it into the coffee where there is no other cream, and that cream is going to spread out through the cup of coffee. It will diffuse into the coffee. Take a sugar cube and a glass of water, okay? The sugar cube is a more solid object because it may be a little bit better example than the cream into coffee. You got your sugar cube, dump it into the glass of water, and that sugar cube will dissolve, right? It started off in one little square centimeter in the glass of water, so it's all concentrated into one spot, and it spreads out into the glass of water to take up, to spread equally throughout that glass of water. Gases do the same thing. What was happening there? Well, the sugar cube was spreading out into all the areas where it wasn't. It was in an area of high concentration, and we let it go, and it spread out equally throughout the area. In the body, your bloodstream has a concentration of gas. We call these blood gases. They are specifically, ones we care about, are oxygen and carbon dioxide. We want the oxygen. We want to remove the carbon dioxide, okay? So in your body, there are blood vessels leading to your lungs. Those blood vessels leading to your lungs to go drop off waste stuff have high levels of carbon dioxide and low levels of oxygen. You breathe in, you bring in fresh atmosphere into your lungs, but that atmosphere right up against your blood vessels, and the atmosphere has less CO2 than the blood vessels do. So what happens? CO2 leaves the blood vessels and goes into the air in your lungs. Okay? Your atmosphere in the atmosphere in the lungs that you just breathed in has high concentrations of oxygen. Your blood has less. So what happens? The oxygen molecules hop out of the atmosphere and into your bloodstream. Okay? When do they stop this? They stop when they have equalized. They stop when there is an equal amount of oxygen inside your bloodstream and outside your bloodstream, in the air in your lungs and in the bloodstream. Oxygen will stop flowing once those two things are equal. And carbon dioxide the same way. Each time you breathe in, you're bringing in some oxygen, some of it's moving into your bloodstream, and every time you breathe out, some of the CO2 in your bloodstream is leaving the bloodstream and coming out in that air. Okay? You are never taking 100% of the CO2 out of your blood. You can't. And you are never taking 100% of the oxygen out of the air. You are taking some of it, with every respiration. You're moving some of it around, and it all happens because of diffusion. Again, diffusion is the tendency of molecules of anything to move from areas where they're highly concentrated and to spread to areas where there's less of them into low concentrated areas. Again, just like taking a sugar cube, plopping it into a glass of water, it will dissolve into the glass of water. Okay, that's important, yeah.
So going back to bulk flow, so that's getting a bulk amount of air into the body, with a certain part of the body's blood vessel?
Into the lungs, like taking a large amount of air into the lungs, right? We end up splitting it up into these small little areas in the lungs, but we take in a big amount.
Okay.
You could, and you actually do, as a small amount, you diffuse naturally some oxygen through your skin. Some oxygen gets into your body through your skin. Now, if we relied on that entirely, you would just die. You know, you hold your breath for a few minutes and you don't get to stay alive, right? You will pass out and your body will take over. But assuming you couldn't breathe, you would just die, right? You cannot survive on the amount of diffusion that our body gets through the atmosphere and skin interaction because we're so big, okay? But you know, I don't know how many bacteria you've hung out with, right? But bacteria, single-celled organisms, do they have respiratory systems and lungs? No, but they're just like us, right? They're we're just all we are just a bunch of cells, right? We're a bunch of cells. All a bacterium is a single cell, okay? Roughly speaking, we're a very similar thing, okay? It has processes that it needs to undergo. It needs to produce proteins for itself. It needs to divide it eventually, right? It needs to, in order to do that stuff, it has to bring in oxygen and excrete waste, okay? It has to bring in O2, excrete waste, and a bacterium can do it through just diffusion. A bacterium doesn't need a respiratory system because it's small, it's a single cell. The oxygen can easily get in and out, the CO2 built up can easily get out, okay? But we are so large that our cells at the surface may be able to diffuse a little bit, but every cell below that cannot interact with the atmosphere to diffuse, so we need to bring in large amounts of oxygen into a space in our body, our lungs, diffuse it into the bloodstream, and get that bloodstream to carry it all around the body and then deliver it to each cell of our body. That's why we need a respiratory system. So all big animals need respiratory systems, roughly speaking. Okay, good. So this respiratory system we can divide into 4 divisions. The pharynx, or throat. What's neat about the pharynx is it's a shared passageway for air as well as all food and liquid. So it's your throat. Everything you eat, drink, and all the air you breathe goes through your pharynx. Pharynx shown up here. You may be familiar with terms like pharyngitis, inflammation of the throat, okay, sore throat. Below the pharynx, where we get a split into posteriorly, we lead through the esophagus down to the stomach, and anteriorly, anterior to the esophagus, you can actually feel your trachea. You have your trachea. It's your hard cartilage tube leading to your lungs. It starts off as a single tube, the bottom of the pharynx. This tube has a top to it, which I'll show you better in just a moment here. And it opens and closes. Okay, it closes when we swallow food, and it stays open when we're breathing in and out. Okay, so this tube can close itself to keep from aspirating liquid and food into other foreign bodies into the lungs. Trachea. The trachea bifurcates. Once you get to a certain point, sort of where the laser pointer's at here, I'll show you better in a moment, the trachea bifurcates into a left and a right side. Those are called bronchi. More specifically, the first splits are called main stem or primary bronchi. Bronchi is plural, bronchus is singular, single bronchus. or multiple bronchi. Those split left and right into a left and a right lung. We'll have to be able to describe how those bronchi appear and how the left is different from the right. That's an important notion. And then the lungs. The lungs are a system of tubes, passageways, leading to tiny air sacs called alveoli, all supported by connective tissue. So the lungs are basically airspace supported by connective tissue. Take a brief look at our upper airway. My phone is like blowing up. Let's zoom in right here. Okay, so we can see our trachea anteriorly. It's a hard cartilage tube. It's a C-shaped, this tube is made of rings of cartilage that are shaped like a C, and they actually open in the back. What that allows is the esophagus behind the trachea, it allows the esophagus to bulge into the trachea as you swallow big chunks of food. A bolus of food causes the esophagus posteriorly to bulge into the trachea, so there's room for that to happen. You'll notice the trachea superiorly at the top has a structure called the epiglottis. Let's just put a highlighter on it there. Okay, the epiglottis, which is it looks like a leaf. From the side, it just looks like a flap, but it's actually shaped like a leaf, or kind of like almost like a tongue, and it flops down right over the trachea every time we swallow food or liquid to, again, keep from aspiration. It otherwise is going to stay open. The epiglottis is connected to a bone called the hyoid bone, which if you look at the epiglottis highlighted thing, just above that is the labeling hyoid bone, and you can follow that line to where it goes. That bone is actually shaped like a C, like that, in the neck, and it's the only bone in the neck. If you look at the neck, there's jaw, mandible up here, spine posteriorly, but it's the only bone down here in the neck. Okay, it's sort of as you can see, like sort of at the base of the tongue, just inferior to where the mandible is. Hyoid bone serves as the attachment point for epiglottal ligaments. Okay. This is the view anteriorly of the larynx and trachea. So it doesn't go from pharynx directly to trachea. You actually go through something called the larynx, and this is the hyoid bone shown in its entirety here. You're looking from the front now. To find your location here, where on the body this is, where the laser pointer is, it's called the laryngeal prominence. You can feel that. That's your Adam's apple. Okay, girls, you got one. You have one too. It's just usually smaller. Okay, so that's your laryngeal prominence. Again, find that in your neck. It corresponds to the level of cervical vertebra number 5. Okay, so C5 level above the thoracic spine in the neck, and below that, beginning at about the level of cervical vertebra number 6, you have the trachea. The larynx, if I didn't say it, is layman's terms your voice box. This is where your vocal cords are contained that give you your voice. You guys have likely heard of laryngitis, right? It causes loss of voice. Okay. Here's a view a little further down. So we had that up there. In this view, they've attached the thyroid gland on there now. So again, you can find your laryngeal prominence. Just below the laryngeal prominence, you're going to have your thyroid gland. Thyroid gland is important, but we're not going to talk about it right now. But it is anterior to the trachea. The trachea extends down into the mediastinum to about the level of thoracic vertebra 4 or 5, T4, T5. So before mid-thorax, a little bit above mid-thorax. The trachea then bifurcates. It bifurcates into a left and a right bronchus. These are breathing tubes, hard cartilage tubes.
So, I'll wait till you get to the lungs.
Yeah, go ahead, maybe you ask it though, and I'll take it, hang on.
In the condition where a patient's born with their heart facing in the opposite direction, the lungs are also opposite?
Yeah, well, not necessarily. There is situs inversus, which is the whole thing switched, lungs and heart, but there's also something called dextrocardia, where the heart is just flip-flopped, and everything else stays the same. So the patient may have one or the other. Yeah, have you ever seen it?
Well, the heart, yes, but.
You've seen dextrocard-
but
dextrocardia
I
is
just
cool.
thought of the question right now because of the structures that I was looking at a little while ago.
Gotcha. Yeah, that's an interesting one. So yeah, and there's like normal, right? And then there's what we call variants. Okay, variants are different than normal. Okay, some of them are normal variants. Others can be pathologic. Typically, dextrocardia, situs inversus, where things are flip-flopped in the chest, are not pathologic. Like, they don't necessarily cause problems for the body. It's just, hey, that's you. You came out backwards, right? They built you looking in a mirror. Okay. Did anybody know someone or have themselves been told that? No? Nobody's got backwards hearts? Okay, all right. I've seen it one time on a patient. It was a kid. But yeah, it's one of those things you may or may not ever get to see.
My daughter's heart is just in the middle.
Differently than normal?
No, just it's in the middle instead of over to the left.
Well, our hearts are midline. Our heart should be in the middle. Have you been told it's different than other people?
Mm-hmm.
Oh, interesting. Okay. Yeah. Did she have any other?
She has dwarfism.
Okay.
Achondroplasia.
Achondroplasia. Gotcha. Okay. That definitely changes shape and structure for sure. Yeah. Okay. Do you have? I mean, I know it's a genetic thing. Typically, do you have it in your family?
It was actually a gene mutation.
She's the first.
Mm-hmm.
Wow, that's really interesting because usually it's a hand-me-down sort of deal, but that's really interesting. Okay. All right. Interesting stuff. Okay. So your trachea. Shown here is your trachea, shown as this sort of gray color, and then you see the different colors representing the left and right bronchus. What I want to talk briefly about, there's a name for the split. There's a name for where the trachea splits to left and right. Bronchi. It's called the carina. C-A-R-I-N-A. And that is the point where the split happens. You should be familiar with where it happens. It's a level of roughly thoracic vertebra 5, T5. Okay. You may be given, and I really dislike when this happens, but you may be given images like this. Okay. Axial image of a chest, and you may be asked to talk about what structures you see, right? And if it's the level of T7, you are below the split. So you won't see a trachea. Okay, you're just not going to see a trachea here because we've already split into a left and a right bronchus by the time we get to the level of T7. Okay, if this were to make it clear, hopefully, this is a cross section sliced through the body, transverse, like that. Okay, so the top of the screen here is the front of the body, the bottom of the screen is the back of the body, and you've got a left and a right side. This is the left side, this is the right side, so they're opposites on the screen. And it's a cross-sectional image of the body. This is at the level of T7, so below the split. Again, if this were T4 or higher, T4, T5 or higher, right here, anterior to the esophagus, you would see a little dark circle that would represent where the trachea is, because you'd be cutting right through that. But in this case, too low. All right, back to here. Your bronchi. They're different. They're not the same. Hopefully you see that when you look at them. They are just different, okay? The right bronchus is very, very short. It's very small, okay? So we only call it a main stem bronchus before it splits again. You'll notice each one of those, there's a split, and then it splits again, right? This one, the right side, can't see that very well, but this one right there, that's it. That's all there is, okay? That is the right bronchus, okay? It splits right here, so that means it stops right there, okay? This is the primary bronchus on the right. These are called secondary bronchi, okay? Each time they split, they're named differently. Primary bronchus, secondary bronchi, and then follow this down again. There's a split here and a split here. These are each going to be called tertiary bronchi, tertiary for third. Okay. Every split after the third one, so you have primary, secondary, and tertiary. Every split after the third one can be called just bronchioles. Okay, small bronchi. And they keep splitting, just like a tree. Picture it's just a respiratory tree. So picture a tree. There's a trunk. Branches come off the trunk, and branches come off of those big main branches, and those secondary branches have branches, right? Eventually you get to some leaves, but the tree branches many, many times before that, right? The same thing is true here in the lungs. It's a respiratory tree. The right bronchus is short and chubby. The left bronchus is long and skinny. Okay? So the qualities of them is the right one is short and fat, the left one is long and skinny. Okay? As well, if you, I need to be able to draw. It's not working for me. Let's see here. Good. If you measured the angle created here and the angle created here, okay, you would find that this angle going down that way is less severe than that angle going down that way. Okay? You would find that if you were to take the path of least resistance downward into the chest, the path of least resistance is to go to the right side of the chest. Okay? And if you were asked to keep continually following the path of least resistance, is it easier to go against gravity upward or just follow gravity downward? Downward, right? So in the chest, the path of least resistance is to the right. So bacteria, viruses, foreign bodies, other things tend to end up on the right side of the chest, in the right lungs, in the right lung. And once you're in the right lung, you can either go up towards the middle or towards the bottom, and it's just easier to keep on going towards the bottom. Okay? So we find that pathologies in the chest, while they can appear everywhere, there's a typicality that they typically tend to go to the right lower lobe of the right lung, to the lower lobe of the right lung. I've seen, and you will see plenty of people who have left lobe pneumonias, okay, but right lung pathologies are just more common than left lung pathologies because of the shape of our bronchi. That's an important note. So physicians will, while they look at everything, they expect things in the right lung more than the left. Now, before they've ordered an x-ray, they've listened to the lungs, they've auscultated the lungs, so they have sort of an idea of what they're expecting to see when they look at the x-ray. But it is true that pathologies tend towards the right lower side. That's not a hard and fast rule, okay? There are obvious exceptions to that, like in the cases of tuberculosis, where tuberculi bacteria, they like oxygen, and oxygen likes to go up. So they tend to find themselves in the upper parts of the lungs, okay? So again, not a hard and fast rule, but a good general thing to keep in mind. All right, so these bronchi, main stem bronchi split, becoming secondary bronchi split, becoming tertiary bronchi, and everything after that are called bronchioles. We don't worry about the in-between. But at the end of everything, when you get to the end, you get to, so that is macroscopic. You can see that, no problem with the naked eye. This is microscopic. You cannot see that with the naked eye. So on a tree ends in leaves, right? Okay. At the end of this respiratory tree, instead of leaves, there are tiny little air sacs, okay, made of a very thin tissue called epithelial tissue. And they are a single layer of epithelium called, which we just call simple epithelium. It is simple, as in single layered, and it is squamous, as in flat. I'm not going to spell squamous for you right now, because you don't need to. But the important thing to know is those little air sacs, called alveoli, are made of a flat single layer of cells. The flat and single layer nature of them makes them very, very thin, and what you don't see in this image are that blood vessels are wrapped around and intertwined all in and around these alveoli, and so these blood vessels are able to butt right up against the alveoli. We get air into the blood vessels. This is where we get the diffusion back and forth between blood vessels. This is the functional part of the lungs, these tiny little air sacs, okay? To give you a number, you have about 600 million alveoli in your total lung, two lungs combined. So several hundred million per lung, okay? This is what occupies most of your lung space, are these teensy little air sacs, okay? it is more beneficial for there to be more small air sacs than there would to be less big ones, and it has to do with increasing the surface area for actual interaction with the atmosphere. These tiny little sacs allow for a lot of surface area for air to interact with blood, roughly speaking. Now these alveoli are what do the work, okay? But you'll notice there's a labeling here at the top left called terminal bronchioles. Those are just the tiny little air tubes, okay, that lead to the alveoli. These terminal bronchioles have blood vessels wrapped around them too. Some of the diffusion happens in the terminal bronchioles. So terminal bronchioles and alveoli are what are doing the work here, okay? How do we get air to flow in and out of here? Well, we create pressure differences in the chest by expanding the chest cavity or shrinking the chest cavity with muscles around there, such as the diaphragm and intercostal muscles. So the alveoli aren't sucking anything in or pushing anything out actively, but because of the big processes that happen in our body when we breathe, air is pushed into and out of the alveoli, and diffusion just happens passively. Okay, diffusion is just a thing that happens when air goes into those alveoli. Yeah, go ahead.
So, so they're permeable. Are there so they're not one way. So
No.
Oxygen and carbon monoxide go simultaneously.
Yeah, both things are
Okay.
happening.
You
So
don't have some alveoli doing oxygen and some.
no. Yeah, so you just get to pick any one alveolus on here. Like look at one of them, and when it fills up with atmosphere, right? You have CO2 from the blood coming into the alveolus at the same time as oxygen is leaving the alveolus into the bloodstream. It's happening at the same time.
It happens because the is it blood on both sides
No, it's air in the alveolus
and then blood inside?
and blood in the blood vessel.
Okay, so in the blood vessel, there's a lack of oxygen. So the oxygen is drawn into it.
Yes.
And then there's a lack of carbon monoxide in the air.
Yes.
So that's drawn out.
Yes. Yes, that's what we were calling diffusion, but as you're saying it, drawing it in and out is a great way to think about it. Absolutely, yeah. And it's happening because, as you said, there's less of one on one side than there is on the other, right? Less CO2 in the air in the alveolus, so CO2 moves from the blood to the alveolus, yeah. That's very good. Good, so there you have it. That is the functional thing that's happening down at the deepest levels in your lungs, and that is the functional unit. Okay. Here's a bigger view, left and right lungs. In this one, we want to show you a couple things. For one, that there is a left and a right lung. That's good to know. But two, that the left and right lungs don't look the same. Okay, they appear differently. They are shaped differently. They are sized differently, and they actually have different numbers of sections to them. Okay, so let's take the left side, for example. The left side is made up of two pieces. We call the pieces lobes, L-O-B-E, lobe. There's a superior lobe and an inferior lobe on the left. The reason for having less lobes on the left is because you make room for the heart on the left. Okay, you notice there's an obvious notch taken out of the medial aspect of that lobe, of the superior lobe. It kind of dips in on the left. That's making space for the heart.
That's why I asked the question, because of the 2 and 3 lobes. So you can have the heart pointing over in the opposite direction.
Yeah, it just makes more room. Those lobes on the right would get smaller. If it was true dextrocardia and everything else was the same, those lobes would just be smaller on the right. There would still be 3 on the right though. Good. The separations between lobes are called fissures. Fissures are taken from geographic terminology where there's like a crack in the earth. It's called a fissure. Spaces between lobes are called fissures. If you took the lungs out of the body, they would be physically separate pieces. Okay. The left lung is, in this image, it doesn't necessarily look like it, but the left lung is longer. It's taller. Okay. It's taller and it's skinnier. Okay, so tall and skinny is the quality of the left lung. The right lung is made of 3 lobes. We have superior, middle, and inferior. The right lung is typically wider and shorter. The shorter is because it has to make room for the liver below it. The wider is because there's less heart on the base, there's less heart on the right side of the chest, so the right lung can be a little larger. And it all does fit in there very well, right? Obviously, because it all grew together, right? So it all sort of fits in together. But they're just shaped differently. That's the first thing to know, is that the lungs have lobes and they're different. The second thing to learn is the lungs take up most of the space of the chest, so they butt right up against the chest, the inner chest wall, and the inner chest wall is going to be muscle and rib, and it's not it's a mucous membrane, but it's not necessarily a smooth surface. Okay, so what you want is a space where you can have slippery fluid. Okay, and so what you end up with, what the body has figured out to do, is it makes a slippery layer wrapped around the lung, adhered to the surface of the lung, and then a second slippery layer wrapped around the inside of the thoracic cage. Okay, making a double layer, or pleura, for plural, for more than one. So you have an outer pleura and an inner pleura, and the space between them called the pleural space or pleural cavity. This is a space where there is fluid, slippery fluid, that allows the lungs to sort of move freely, taking up the whole space, but moving freely without rubbing up against ribs every time you breathe. Okay. In certain cases, there can be infections in the pleura, and it becomes very painful to breathe because that extra accumulation of stuff creates friction, and the friction hurts when we breathe. So we call it the pleura, or pleural space, and it's made up of two membranes, the parietal pleura, which is the outer one, and the inner pulmonary pleura, the inner one. Let's talk about the mediastinum. The mediastinum, it's the portion between the lungs. You have the trachea in the mediastinum. The esophagus is posterior to the trachea. The thymus gland, which sits anterior to all these other structures and superior to the heart. There in this image is the thymus gland, kind of hiding behind the lungs and in the middle. And you have the heart and great vessels. No one's in there, right? The toilet bill. I got it. Heart, it's obvious. So let me show you another image, and it'll help a little bit with this, because it subtracts the lungs. So this image is the chest with the lungs subtracted. Obviously sternum has been subtracted, and all the cartilage coming from the ribs to the sternum. So what you can see here is a better view of the heart. Okay, notice that the heart is a roughly midline structure with some of its with more of its mass to the left than there is to the right, which is why with the Pledge of Allegiance we're taught to put our hand over the left side of the chest, even though the heart is basically midline. And it is the biggest structure in the mediastinum. It's the most anterior structure in the chest, aside from the bony thorax stuff. The heart, the apex of the heart, sits more anterior than any other soft tissue structure in the chest. It butts literally right up against the ribs and sternum. What we mean by great vessels, so we say heart and great vessels, what we mean by great vessels are all the big blood vessels coming into and out of the heart. Specifically, you have the ascending aorta leaving the heart, going up and branching behind the heart. You have the superior and inferior vena cava, shown in blue and on the right side of that person's chest, coming from above and below the heart, superior and inferior. That leads to the right atrium of the heart. And then you've got the pulmonary vessels, pulmonary for lungs, and these pulmonary vessels hide behind the heart. You can sort of see them poking their little fingers out to either side to either side of the heart at the top. These vessels lead to the lungs to take deoxygenated blood to the lungs. We call those pulmonary arteries, and then bring oxygenated blood back to the heart. We call those pulmonary veins. Those are the only time in the body where arteries and veins switch roles. Every other time, arteries carry oxygenated blood, veins carry deoxygenated blood. But in the case of getting blood to the lungs, the roles will switch. Okay? Pulmonary arteries carry deoxygenated blood, whereas pulmonary veins bring the oxygenated blood back to the heart. There's our mediastinum. You can see this laterally as well. The importance of looking at this laterally, so you're looking at this from the side, okay? The lung on this side, which has to be the left side, has been subtracted, and the ribs on the left side have been subtracted. So you get to see the big lung cavity here, the diaphragm at the bottom. But what I want you to focus on is, for one, there's this big old arching aorta here. You can see the aorta go up out of the heart and down like that. But I want you to focus on this right here, okay? There is a pulmonary artery, a pulmonary vein, in fact, two of each, okay? There's bronchus coming in from the trachea here. This is an area where many, many big vessels are coming into and out of the heart, okay? And so it's a concentration. It's where blood will become concentrated as it moves back to or away from the heart. Either way, it's a concentration point. We call this the hilum. Okay, so when you hear doctors talking about the hilum in the chest, they're talking about this spot in the chest. Okay, they might say like, this chest x-ray demonstrates hilar enlargement or something like that. Okay, they're talking about this space here, the hilum. Or hilar congestion, which is really common in congestive heart failure, for example. This spot right here is what they're talking about. Okay. Let's try now to, and I only a couple more minutes here. Let's try now to take a look at a couple of chest x-rays, and let's try to look at some of the anatomy, see if we can point out some of the anatomy, okay? So first off, this is a front view chest x-ray, and I should have said this earlier, but chest x-rays are sort of the most common type of x-ray that are taken. I mean, if you know nothing else and have done nothing else and do nothing else ever, you got to know how to take a chest x-ray, okay? Because it is the most commonly ordered radiographic exam, period. And for a good reason. It gives you the physician a lot of information about what's going on inside the body. Before we learn about pathology, we have to learn to recognize what's normal, which means we have to be able to recognize anatomy, okay? Let's go ahead and walk this through. Maybe use something to point at something with. Let's use that. All right, let's just kind of go through the alphabet here, starting with A. So here's our chest. This is a front view of the chest. We typically call these a PA chest x-ray. PA, we'll get to more next time, but it stands for posterior-anterior. What it's actually describing is, it's describing the path that the x-ray beam took through the body, something called the projection, okay? Said it another way, the patient was facing towards the board, the x-ray beam came in through their back, okay? But it's still, we call it a front view of the chest, because you're looking at it like it's from the front, not from the side, okay? That said, lots of things on here, okay? Let's start with A. A is actually outlined because it's kind of hard to see. A is the air-filled trachea. Okay. Next time when we meet, you'll learn that when chest x-rays are done, they have to be done on a full breath in. Okay. The patient takes a full breath to expand the lungs. Well, when they take a breath in and hold their breath, their trachea becomes full of air. Okay, as well as their lungs. So we get an air-filled trachea. We want to see the air-filled trachea. You can see the air-filled trachea as a slight density here. Remember, density is blackening. A slight density here. A slight density here. That one's not so good. That's one reason why this was too bright. Okay, this needed to be denser, darker. But there's the air-filled trachea. They've outlined it for us here. Okay, let's look at B now. B is just pointing to the top of this big dark outline. These big dark outlines here. So B is actually pointing to the top of the lungs. Okay, the tops of the lungs are called apices. We can see the very tops of the lungs here, 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 there, and there, okay? It's not one specific point, it's just that whole rounded top of the lung, called the apices of the lungs. We need on every chest x-ray, we must be able to see the apices of the lungs. One of the requirements for chest x-rays is to demonstrate the entire lung field, okay? So if you cannot see the apices of the lungs, you haven't gotten far enough up, on your image. Okay, you actually have to repeat the image if you don't get the apices. So that's a requirement. You look at the apices of the lungs, are they there? The next thing, let's just go straight through this. C. Now it's not easy to see on here, harder to see with all the lights on in here, but can be done. You can follow the trachea down to where it splits into the left and right, and it's very, very subtle, okay? So on this one, they've helped you, and they've just outlined it, okay? If we turn the lights off, look really close, we'd see this a lot better, but this starts off a little dark here, and then if you look really, really close, this is all behind the heart. Remember, the trachea is behind the heart. So it splits into a left and a right primary bronchus. So what's C pointing to then?
Carina.
The carina, good, the split between the left and right bronchus. Let's go next to D. D is indicating, well, yeah, okay, that's what D's pointing at. D is indicating the bottom of the lungs. Now the lungs are curved at the bottom. They're curved because below the lungs is a muscle called the diaphragm. And the diaphragm is actually two muscles, it's two hemispheres. So you have a left hemidiaphragm, a curved muscle on your left side, and a curved muscle under the right side, left and right hemidiaphragm. But D is pointing to the bottom of the lungs, the curved bottom of the lung field. On normal patients, the bottoms of the lungs have this curvature to them. Curved, curved, still curved, curved, okay? We call the bottoms of the lungs the bases, okay? So you have the bases at the bottom, the apices at the top. Every chest x-ray must demonstrate the base of the lungs all the way down to this point. Notice how the lungs come out, curve down, and there's a point here where they kind of cut the side and the base come to that point. That point will be labeled here. We'll talk about in 2 more letters, okay? Let's go to another one, all right? So we have the base of the lungs labeled as D. E is actually pointing to a rib on either side, okay? One important thing to do on a chest x-ray, one of the evaluation criteria for a chest x-ray, is to make sure the patient took a big enough, deep enough breath, okay? So what happens is when we breathe, our diaphragm drops down, expanding our lung field. When you breathe in, diaphragm comes down. When you breathe out, diaphragm pushes up, okay? So when you go and go full breath out, diaphragm is at its highest point, and when you go full breath in, diaphragm is at its lowest point. All right. When we take a chest x-ray, the chest x-rays are better with the lungs expanded, okay? And because we want the lungs expanded, we've made a evaluation criteria where we say we have to be able to quantify how expanded the lungs are. The way to do that is by comparing where the lungs stop in relationship to other structures that don't move. Well, one structure that doesn't necessarily move are the ribs where they're attached to the spine in the back. Okay, call them posterior ribs. The first rib is up here, and I can show you just curves around like that. There's the first rib. Okay, that's thoracic vertebra rib number 1. Thoracic rib number 1, excuse me, on the right side. Now, because the thorax has kind of a curve to it, the first couple sort of appear as though they're overlapped on top of each other, even though they're actually not on the real patient. This is part of that distortion thing we were talking about earlier. There's always some distortion present on an image. Okay, but anyways, what you're going to need to do on a chest x-ray is count the posterior ribs to make sure that you can see enough of them. The rule is you must show at least 8 posterior ribs. How many do we have? How many ribs do we have? 12 sets, right? So you're never going to show all 12. Typically, we show anywhere from 8 to 10. 8 is minimum, 10 is ideal. So let's count it. There's rib 1. It's easier, by the way, to count next to the spine. Also, too, let's look at just this rib here, okay? This is where the second rib starts, but if you follow it out, it starts up there, but it ends like over here, okay? Ribs begin high in the back, and they come down as they angle towards the front. So you need to make sure you're counting the posterior ribs. Posterior ribs always point kind of downward, whereas the anterior ribs are angled like that, okay? Let's count posterior ribs. There's 1, there's 2, there's 3. 3 is hidden behind the clavicle here. There's 3. There's 4. It gets easier now. There's 5. There's 6, 7, 8, 9, 10. Ooh, this person gets 11. They got a long chest. 11. Okay? I got 11 ribs above the diaphragm. Okay, I've counted 11 posterior ribs above diaphragm. Did they breathe deep enough? Yeah, definitely, right? They have more than 10, which 10 was the ideal, okay? And so you need to count that. You count posterior ribs, and every chest x-ray needs to show that. If you look at your chest x-ray that you just did, and you can only find 7 posterior ribs above diaphragm, you have to repeat the chest x-ray the next time, giving better patient instructions, okay? One of those that people often gloss over is the breath in and holding the breath should be done on the second breath in, not the first. So most x-ray techs get lazy and they go take a deep breath, hold your breath like that, right? If you tell somebody just take a deep breath and hold it, they will not breathe as deeply as if you let them take 2 breaths. The second breath in will always be deeper. The lungs expand more on the second deep breath. Let's go to F. F is more subtle on here, but is less subtle over here. You can find this easily on this one, where the base of the lung, you can follow it out, comes to a point, along with the lateral lung field coming to a point right there, okay? That is a point here and down over here that we call the costophrenic angle. So it's the angle created by the lungs that butts up next to the ribs, the costophrenic angle. It marks the true bottom of the lungs, okay? What does liquid like to do? Does liquid like to go up against gravity, or does it like to pretty much go with gravity? Yeah, water pretty much goes with gravity, right? Well, most disease processes are largely water, right, in the body. So if there's something like a pleural effusion, which is a fluid in the pleural cavity, there's something like an infiltrate, an infection in the lungs, these things tend to settle down low, okay? And especially things like pleural effusions where you get fluid into the pleural space, it's gonna find, because water finds its natural lowest point, it's gonna find the lowest point in the lungs, okay? If you took a chest x-ray, but didn't include the costophrenic angles, what if they were full of fluid? You could see it if they were full of fluid, if you showed them. If they're full of fluid and you showed it, you could see it. But if you didn't show it, then you'd have no way of knowing if the costophrenic angles are preserved or not. Let me show you an example.